Hey, this is Lori Lennicky again, finishing up the spine lecture. So there are times when lumbar surgery has to occur. Conservative management failed, neurological damage is too high, whatever the reason. I'm going to talk to you about some common surgeries. Doing a podcast like this, I can show the videos that I have on the next few slides, but the volume won't come through. So at this point, what I need you to do is hit pause on this video, and I want you to go and look at the PowerPoint that's in the same folder as this video. Watch the video on laminectomy, watch the video on lumbar discectomy, on spinal fusion, okay? And then go ahead and hit pause, go do that, and then come back to me. All right, so now that you've watched the videos, we need to talk about what we would do with these patients post-operatively. One of the big things is patient education. You need to educate the patient on the expectations of the surgeon, on the surgical procedure, and what rehab is involved. Also, make sure that they know what is not allowed. This is another good time to talk to the surgeon, to think through the reasoning of what surgery happened and what movements you don't want to do and what do you want to encourage. Typically, restrictions are no heavy lifting, um, no significant range of motion, like you don't want to do a lot of lumbar or cervical flexion or extension. But further limitations may also be imposed depending on the surgery. And during this maximum protection phase, so early after surgery, you also want to teach the patient about wound management. Let them know what the signs and symptoms of infection are, what to do if the wound opens up, how to control the edema around the scar. At this point, you also need to show patients how to perform bed mobility while they may be in a brace. They need to know how to get up and out of bed safely without damaging the surgical repair or fixation. Typically, this involves bracing the spine, rolling into side lying and hook lying, side lying, and then dropping the feet off the edge of the table and sitting up without moving the spine. Many times after surgery, patients will be in braces. It will depend on the type of surgery they had. So in the cervical spine, it may be what's called a Philadelphia collar, and then progressing to a soft collar. The Philadelphia collars are the harder plastic ones. In the lumbar spine, you may have a brace that prevents movement. There's one called a TLSO, a thoracic lumbar stabilization orthotic, and it prevents you from being able to bend forward. But there's many types of different braces that might be used. And for this maximum protection phase, you want to begin gentle range of motion exercises of the upper and lower extremity, trying to maintain some form of stabilization in the spine. So performing quad and glute squeezes, ankle pumps, heel slides. This is good to get circulation in the lower extremities. You also, if they've had a laminectomy, you want to avoid any excessive spinal extension early on in this phase. All right, so once a patient has gotten through that maximum protection phase, so early after surgery, and they are starting to progress and some time has been, just time has allowed some healing to occur, you can change and start doing a little bit more. At this point, we want to work on scar tissue mobilization. This can be from the incision site or any connective tissue surrounding the area. You want to do progressive stretching of and maybe some joint mobilizations of any restricted tissue. Remembering that we do not do joint mobilizations over fused areas, and I would avoid any mobilization or manipulation in the surgical area. Start working on muscle performance, especially of the global and segmental stabilizers of the spine. And work with gait training. We want patients to be able to ambulate independently, and this is a good time to start working some endurance with ambulation. You must continue to follow all the surgical precautions and be very careful with extension exercises in patients who've had a laminectomy. As the patient progresses, you'll work towards improving their impairments and regaining full function once the surgery site has healed. Right now, I'm going to talk about some other lumbar problems or spine problems, I should say, that are very common. So, one is a compression fracture secondary to osteoporosis. What happens is the lumbar vertebral body, because of the kyphotic posture, will begin to wear away, and you will get compression fractures without any real major trauma. So, often these occur without patients knowing that they occurred. But the symptoms can be provoked with flexion exercises. So as you flex more, you will be putting more pressure on this anterior pillar of the spine, and that will increase pain. Interventions for individuals who have compression fractures secondary to osteoporosis include stabilization exercises in neutral, postural correction. You don't want them to continue that kyphotic posture that puts a lot of pressure on this fractured area. You can begin to stretch tight muscles and instruct on correct lifting techniques. You don't want them bending over, even to lift their groceries or to pick something up off the floor. You want to avoid trunk flexion exercises. Anything that flexes will increase the pain and increase the problems this patient is having. Next problem is spondylolisthesis. Now, there are many problems in the spine that can be confused. There's spondylolysis, spondylosis, and spondylolisthesis. If you don't know the difference, it's a good time to go look that up and make sure that you understand the difference among the three definitions of spondylolysis, spondylolisthesis, and spondylosis. What we're talking about here is spondylolisthesis. This is when there's a slippage of the vertebrae, on the superior vertebrae on the one below. So we'll start with a grade 4 because it's most easy to recognize. As you see, this vertebrae has completely slipped forward on the lower one. This would be L4 slipping on L5. If you have more than 75% of the vertebrae moved past the end of this, that is considered a grade 4. So here would be normal. This one is just starting to slip. Less than 25% of it has slid forward. Grade 2 is between 25 and 50. Grade 3, 50 to 75. So with individuals who have this, you want to work, as you can imagine, on stabilization exercises and work on flexion. Extending would only make this worse. Hip flexor stretching is typically needed because of the pull of the hip flexors and where they locate on the anterior part of the spine. For this, you could do a grade 2 or grade 3 mobilization for pain, but you would avoid any manipulation or any grade 3 or 4. You don't want to try to increase motion in these individuals. You need to stabilize them. Next, we have ankylosing spondylitis. We talked about this a little bit earlier, but we'll get into more detail now. What happens with ankylosing spondylitis? It's a rheumatic disorder that occurs when you have ossification of both your anterior and posterior longitudinal ligaments, and you get some ossification of the facet joints. It usually appears in adolescence and peaks in around the mid-20s. So this is a disease of younger individuals. And people with this pathology typically have pain throughout their spine. They may even have pain in their shoulder and feet. Symptoms of those who have ankylosing spondylitis include being stiff after sitting for about 30 minutes, have back pain that that improves with exercise but gets worse with rest. And people who have back pain only during the second half of the night. So they're fine when they go to bed, but usually after being there a while, their pain increases. If they get up and move around, it goes away. So for these patients, you treat them with education on proper posture, making sure that they can stay as functional as possible. Gentle mobilizations, grade 1, 2. Again, this is not somebody you would want to do a grade 3, 4 or a manipulation because they are starting to get fused. Work on segmental and global trunk stabilization, scapular stabilization, and stretch out any tight muscles that may cause an increase in abnormal posture as this tightens up. And next we have Scheuermann's disease. This is a disease where you have weakened vertebral end plates. Often the nucleus moves either superiorly or inferiorly due to these weakened end plates. This causes a breakdown in the weight-bearing ability of the anterior pillar of the vertebrae. Patients typically have an increase in kyphosis that's pretty significant. These patients typically don't have any radicular symptoms because the nerve root isn't involved. And if you think about somebody who has an increase in thoracic kyphosis, their foramen is actually larger because of that flexion. So how do you treat these individuals? So you work on stabilization exercises, stretch the tight muscles, and work on postural education. You hope that the breakdown of the vertebrae occurs in a more even area so that you don't get the wedged shaped vertebrae. Right, cervical and upper thoracic region, a tension headache or a cervical headache. I'm sure we've all had headaches, and there's many different causes. They consider headaches in three categories. Primary, which would be a migraine, a cluster, or a tension headache. A secondary headache, which is caused by some other disorder, and cranial neuralgias. So secondary headaches can be from cervical spine impairments or from TMJ problems. You should realize that about 15 to 20% of people who have chronic headaches are diagnosed as cervical headaches, and they have a musculoskeletal impairment. So there will be times when you're referred a patient for a headache and you think, what can I do other than give them some ibuprofen? But there are many things you can do in the cervical and thoracic spine to help this patient. All right, so how are cervical headaches different from other headaches? They're usually, they can be unilateral or bilateral, but usually you have one side that is predominant. You may also have pain in the suboccipital region that spreads into the head. The intensity can fluctuate between mild, moderate, and severe, and sometimes it's precipitated by sustained neck postures or movements. People who tend to get pain when they're sitting at a desk or driving in a car or watching television, they may have cervical pain or cervical issues that are causing that headache. It can be related to trauma, degenerative joint disease, or sedentary lifestyle, and it is more predominant in females, but males do get the cervical headaches. When an individual does complain of a cervical headache, there's some red flags you need to take into consideration. If somebody says it is their first or the worst headache they've ever experienced, it may not be related to the cervical spine. Any sharp pain or spikes in intensity, or headaches that come in bunches, such as throughout the day or over several hours. Also, if a change in personality or behavior is reported, it's probably not just a headache, and a referral to a different medical professional may be needed. All right, so how do we treat these tension and cervical headaches? Postural correction is one of the big things that we need to do. We need to make sure that their ligaments, bones, muscles are not put in a significant amount of stress. Also, what you would do for postural impairments, such as strengthen the weakened muscle, stretch the tight muscle. Very important related to cervical headaches. And making sure that they have a proper chin tuck and are not in extensive upper cervical extension is important. Manual therapy, suboccipital release, these are all good techniques to use with somebody who has a tension or cervical headache. And finally, our last two diagnoses, cervical radiculopathy and cervical myelopathy. The cervical radiculopathy occurs when a patient has pain that extends into the arm. It can be referred pain from a result of many different conditions. Interventions for cervical radiculopathy include trying to do whatever it takes to relieve the symptoms. So it may be cervical traction if there is a nerve root impinged, maybe stabilization exercises to emphasize proper posture and strengthening of the deep cervical flexors. Postural training with emphasis on postures that relieve symptoms are needed. Cervical myelopathy occurs when there is compression of the spinal cord. If this is in the cervical spine, you can get symptoms in all the extremities, in both hands and both feet. And the therapy intervention is based on what impairments you see and being able to identify the cause of the problem. The pathology can be caused by degeneration, stenosis, or spondylosis, and your intervention may vary depending on the cause of the pain. All right, that's it for this video. Thank you.